that I am going to start our program tonight and introduce our first speaker, Dr. Carmen Perez, who is an assistant professor in the Department of Radiation Oncology here at Perlmutter Cancer Center. Let's welcome Dr. Perez.
Okay, good evening. Thank you for being here, and thank you for the opportunity to share with you some highlights by radiation oncology that were presented in the San Antonio conference that happened in December. So I'll present some highlights that can be divided in these 4 topics, basically improving convenience of radiotherapy, research on predicting high-risk patients, and understanding toxicity from radiation therapy for breast cancer, as well as give you present 3 interesting ongoing clinical trials that have to do with radiation for breast cancer. So the first topic for the research is this improving convenience of radiotherapy. Just for those of you that may not be as familiar with what is the role of radiotherapy for breast cancer, in most cases there's a surgery first, and then that's followed by radiation if the surgery is a lumpectomy to the breast, if the surgery is a mastectomy to what's left over in the chest wall or the nodes. When we're looking at breast radiation, there are different options. The more traditional option is this conventional schedule. If you imagine that each of these rectangles represent a day of the week, and the purple ones are days of the week when you get radiation. So you get radiation 5 days out of a 7-day week, and that whole process conventionally takes about 6 weeks. The alternative is actually something called a hypofractionated schedule, where now if you look, the rectangles are a little bit wider because the dose that you're getting every single time is a little bit higher than on the conventional schedule. The benefit of that is that you're able then to finish in a shorter period of time of about 3 weeks rather than 6 weeks. The other alternative is something called partial breast irradiation, which you'll see on future slides as PBI. And in this case, the doses are even bigger, but because you're treating only part of the breast, you're able to do it much, much faster. So most of the time, either 5 fractions or 3 fractions. So this study that came from Italy asked the question whether there's actually a quality of life benefit that can be detected in patients that get treated with this partial breast irradiation compared to those that get the whole breast treated, with the hypothesis that that would be the case. So in this study, they had about 200 patients, and they were in a clinical trial where half of the women received the whole breast radiation and half of the women received the short partial breast radiation. All of them were given this questionnaire that's designed to measure the quality of life in cancer patients, and they looked at the data before the radiation and then 2 years after radiation. Before the radiation, the results were comparable between the 2 groups. But then after radiation, again, in the questionnaire, there were multiple things being measured. And when you compare APBI, the partial breast mean scores, with the whole breast mean scores, you see that, for example, in the symptom scales, for example, breast symptoms, these were lower for the patients treated on partial breast compared with the ones treated with whole breast radiation. Same thing with arm symptoms, and even the complaints that they had regarding their systemic therapy, that would be chemotherapy or endocrine therapy. Some of the functional scales metrics were also better for partial breast irradiation, including the woman's body image perception was slightly better for partial breast, and their perspective on the future. Interestingly, they didn't detect any difference in the sexual functioning or enjoyment between the 2 arms. So this other study came from Canada, and this has to do with the other strategy that I mentioned of hypofractionating the radiation, where it takes 3 weeks rather than 6 weeks of treatment. And typically, that is done when you're treating only the breast, because that's what the big clinical trials that justify doing it showed. But it would be interesting to see if it's just as safe to do it when we need to treat regional nodes to make those treatments convenient as well. So they looked at patients that were treated in Canada starting in 2007 through 2010. They were treated with what's called 3D CT plan radiation, which basically it's a fancy way of saying that it's modern day radiotherapy. And they were all identified from different provinces in Canada, and they were sent this survey of self-reported arm symptom scale. So they had a lot of patients, over 1,700, and about 50% returned their survey. So they ended up with data for 708 patients, where 406 were with the short regimen or hypofractionated radiation, and 302 with the conventional. So you see that the hypofractionated arm compared to the conventional fractionation arm, the p-value over here is going to tell you if the findings, the differences are statistically significant. Something lower than 0.05 would be the case. So here highlighted in yellow, you see that arm movement was found to be statistically significant, but actually in favor of the short course of radiation. And the same thing for some of the functional assessments that they did, such as reaching the presence of these problems, where there were lower problems in the hypofractionated arm than in the conventional arm. So this study really was very interesting because it supports a notion that we could do this convenient treatment not only for patients needing just the breast irradiated, but also the nodes irradiated. Then another very interesting research area is trying to find out which patients we actually don't need to even treat with radiation, where radiation could be safely omitted. And there was a study presented from Sweden where they looked at patients that had low-risk characteristics. They're defined over here. So basically age older than 65, clear margins, and patients that had small tumors and are planning to do hormonal treatment with tamoxifen or aromatase inhibitor. And they looked for these breast tumor recurrence. It was a large study of about 600 women. And none of these women actually underwent radiation. And as you can see, with a relatively short follow-up, a decent follow-up of 5 years, you can see that the incidence of that recurrence of the breast cancer coming back in that breast, even though they underwent a lumpectomy but no radiation, was very low. It was only 1.3%. So this supports other data that suggests that in certain groups of low-risk women, we could actually not treat them with radiation. A similar study was presented from Japan, where now they even went down to 60 years of age, with the caveat that the majority of the women were 70. And this was actually randomized, and some had radiation and some didn't. And you see that in the group that didn't do the radiation at 10 years, so double the time follow-up from the first study, it was only 6.7% compared to, as expected, a little bit lower with radiation. So if we go back here, even if you fall, it's a low risk, but even if you fall in that 1.3%, you would like to know ahead of time that you're going to fall in that percentage of patients where things can come back. And a lot of research goes into trying to predict who are these high-risk patients. So this group it's a collaboration between Michigan and the Netherlands. They're trying to see if, by looking at the blueprint of the cancer cells, which is the DNA of the cancer cells and expression of genes from that blueprint, can they define a signature that maybe it's basically a red flag that would be able to tell us if a tumor is more likely to come back or not. And they were able to do this, and in a validation data set which was presented at San Antonio, they showed that for patients that have a signature, a gene signature that predicted non-recurrence, so cancer that won't come back, it actually didn't recur. So most of the patients were cancer-free at 20 years, but that wasn't the case for the ones that had the signature that predicted recurrence. So this is very exciting, but of note, this is not something that's commercially available. So in clinic, we cannot use this signature as of right now, but that's probably something that's coming in the future. Another study related to the subject is when we think about patients in which we don't need to do radiation, typically we think of patients that undergo a mastectomy and their nodes are negative. So this particular study looked at, is it always safe to do that? And it was a retrospective study where they looked at over 600 patients None of them underwent radiation, and they had to have small tumors up to 5 centimeters, node negative, and they could have at least one of these high-risk features of young woman younger than 40, lymphovascular invasion, or these other ones mentioned over here. What's interesting is that among those patients, even if when they didn't do radiation and had high-risk features, the recurrence rates were very low at about 6 years. It was only 4.7%. And the only feature that seemed to put them at higher risk of having local regional recurrence was having a bigger tumor between 2 and 5 centimeters and not receiving systemic therapy. So this is informative, and it really helps in when you're making a clinical judgment about people where you can omit radiation. So the reason why we try as much as we can to identify patients in which we don't need to treat with radiation is because we want to minimize toxicity, of course. So in this particular study, presented by Reshma Jaxi, she presented the results of a multi-institutional prospective study in which they looked at what are the complication rates after mastectomy and breast reconstruction for patients that undergo radiotherapy. So the study population ended up being about 500 patients that received radiation after their mastectomy and reconstruction, and about double of the patients for a comparison group were not irradiated. They looked for complications, failure of that reconstruction, as well as quality of life outcomes. So by 2 years, there was at least one complication, and this is a broad definition. This could include an infection, this could include a collection of blood or serum in that area. It occurred in about a third of patients that were radiated and about a fourth of patients that were not radiated, which is, it's really in line with what we know from other types of study, retrospective studies. And then the worst complication in terms of reconstruction would be a reconstruction failure. And by 2 years, it occurred in about 11% of patients that received radiation, and at lower numbers, of course, in patients that were not radiated. And in this particular study, it was the difference was more marked when the reconstruction was implant-based as opposed to autologous, or when they use a flap from your own tissue. Regarding the side effects, this other interesting study from Emory was presented, where they looked at the side effects on the skin when they were comparing, again, that conventionally fractionated radiation with hypofractionation. It was about 100 patients, and they obtained measurements by ultrasound, which is depicted over here, of the breast that wasn't treated and the breast that was treated with radiation. So even though you see that there's more lucency over here on an affected breast, even before radiation, just from the surgery changes. And then 1 year after radiation, you can see that that change persisted on the irradiated breast. So when they did this, they saw that actually the conventional radiotherapy patients, or 6-week patients, are in blue, and the hypofractionated radiotherapy patients are in red. You see that the thickness, or that change on the skin, was, if anything, smaller in the group that received the shorter therapy. So again, supporting the use of the more convenient, shorter regimen on patients. So just briefly on 3 interesting clinical trials that are thinking a little bit out of the box. So this is one that is being done at MD Anderson, and it's asking the following question: is it safe to not even do breast surgery in patients that are detected to have breast cancer? They undergo first chemotherapy, which is the concept of neoadjuvant chemotherapy, and then from a biopsy, after they complete the chemotherapy, they have a complete response in the breast. There wasn't anything left in that biopsy. So it's called it's an exceptional responders trial. It requires that the cancer is small, T1 to T2, so not bigger than 5 centimeters, and either no nodes that are detected on examination, or less than 4 abnormal nodes noted on an ultrasound. They accept basically any. They have to be HER2 positive or triple negative, specifically because those are the ones that are more likely to respond to neoadjuvant chemo, and they want the patients to be 40 years or older. So they undergo that chemo, Then they do a biopsy. And then if the biopsy shows what's called a pathological complete response, which means that there's no leftover cancer in that breast, the breast is not, there's no more surgery in the breast, and they receive radiation. They go to an axillary dissection if they had no nodes. So the surgery would be limited to the axilla and not the breast. So a lot of, it's an interesting trial, be interesting to see what it shows, some controversy about it. So this other study asked a question from Ohio State University, and it's asking the question, is it safe to treat patients with radiotherapy before they undergo the lumpectomy? So is it safe to switch it around? And the whole idea is that if you are able to localize that tumor, you probably can end up treating a smaller area of the breast compared to when you have to treat a lumpectomy cavity that has removed a lot of tissue already from the breast. So it requires the ability of the woman to lie on a table, lying on her belly, and do an MRI and a CAT scan, and then they're doing this treatment, and then the woman still undergoes the surgery, with the idea that they're going to look at toxicity and cosmesis, thinking that because you're treating a smaller volume, those are going to be better. And this is basically what I had mentioned. Of note, the treatment that they're using in this trial is that partial breast irradiation approach. The last study that I mentioned has to do with patients that have metastatic disease. And in this study, it's a national study in which patients that have limited metastatic disease, the question being asked is, is it beneficial to consolidate treatment to those areas of metastases? So it has to be someone that has not more than 4 metastases, either in the lung, bone, or spine, or no more than 2 metastases in other organs like the liver, the central lung, or the mediastinal or cervical lymph nodes. And they have to be pathologically confirmed and visualized. And then they're going to get randomized. So either they just get systemic therapy, which means just chemotherapy or endocrine therapy, or they get that and some sort of treatment to kill the cells, to attempt to kill the cells in the metastases. And that definitely can be stereotactic radiotherapy. It's planning to accrue about over 140 patients, and they're looking for improved progression-free survival, the cancer not progressing as fast in the women that get treated in this metastases. And then if that works, they're going to accrue over 400 patients to look at actual overall survival benefit. Okay, that's it. Thank you.